We've heard enough from Dr. Gaurav and Dr. Priya as to why all the cataract surgeons should now move on to the refractive. And I would just put it in one line saying everybody's dil mange more. So the patient wants more, the surgeon wants to improve his skills. So here we are in this session discussing why we should become refractive from just a cataract surgery. So, when the starters, when you're starting, there's so many things which you heard about presbyopic lenses and other stuff, issue with contrast sensitivity, glare, halos, that could be a problem in the vision. You're asking your patients to more, and even the established surgeons hear this once in a while, doctor, maza nahi aaya. So how do we start right? So for people who are starting and going on to presbyopic correcting IOLs, know your choices. First, read about them, talk to your colleagues. So these are the options that you have, and we'll just go one by one as to how to choose the correct lenses for your patient. First and foremost important thing is when you're starting out, select, everybody's spoken about, patient selection. I would say look for patients who are selfly motivated. They come to your OPD and they have looked at these options. Maybe you have brochures outside, posters talking about refractive options, and they ask you. So these are good patients to select. Realistic expectations, you don't want too much hassles later on, so fine. To all said and done, diffractive IOLs do have in certain patients, night glares and halos problems. So I would avoid them. Clinically, very important. Just broadly, when you start looking at the patient at the slit lamp, make sure that you're looking at the lids. There should be no mebomitis, no ocular surface. Do your Sharmas, do your T-puts. Make sure that the tear film is okay, because that could make your 6x6 a very unhappy 6x6 post multifocal lenses. Look at the topo, rule out very high order aberrations. Make sure that the retina is normal. So you may not charge the patient of a macula, but make sure that he's sitting on an OCT you run through so that you detect any early epiretinal membranes or early trucents, right? Look at the astigmatism, because then we will plan accordingly. Okay. Now, which is your best patient to pick up when you start? Look at a hyperopic patient. He's going to be very grateful to you. Pick up low astigmatism to begin with, no astigmatism preferably, because once you've mastered the art of presbyopic, then we'll tell you how to go on to choosing multifocal and astigmatism. Bilateral preferably, because they are much happier that way. It's all about the summation at the brain level. And as I said, make sure that there is no other ocular pathology. We wanted you to know as an audience, people, the starters, that you don't need fancy equipments. Whatever you have in your clinical practice, as everybody has pointed out earlier, Dr. Chitra and Dr. Gaurav, use immersion A-scan. You're not doing corneal compression that way. So you are very sure of your axial length. When you look at kerato, I'm sure you have a manual one, you have an auto, you have a topo. So try and look at all the readings so that they match. I normally tell them, look at the multiple readings. I go for the power on manual, auto, if, at one of the centers, I don't have fancy equipments. And I look at my axis on the topo one. Pick up your data pre and post, give it to a company person so that he can calculate your surgical induced astigmatism. It will help you a lot in personalizing your A constant. As pointed out earlier by the speakers, this is a boon. You don't need fancy optical biometers. All what you have to do is with your readings together, which you're very sure of now, go on to these sites and there you have your precise IOL power to choose from. Now, this whole gamut of which lenses to choose from. Talk to your patient, understand the visual needs. Is he just into reading? There is no intermediate work, or he's not into reading at all and prefers big screens when they are doing work. So those kind of his day-to-day routine. Understand their comfort level of paying. There's no point pushing a low-paying person premium lenses, and if he's not happy, later on it's going to pinch him a lot. So these are small practical tips which you should keep in your mind in OPD. Talk to your colleagues. Don't start with just, Indian, I don't want to say Indian companies are bad, but something which has not been tried and tested. You don't want to burn your fingers initially. Talk to your colleagues who've been using lenses and then go accordingly. I want to sensitize you to how important the intermediate vision has now become just then the reading. So you've seen the evolution of presbyopic lenses from where we started from a +4 reading correction, because it was all about reading. And now we know that intermediate correction at 6 to 80 centimeter is much more important. So this is the whole gamut of lenses options for you in trifocals, extended depth of vision. Now we have extended range of vision lenses. So this slide is just to give you an overview that there are that many lenses out there. Broadly, what your diffractive lenses are doing is basically making different multiple foci so that you get an extended range of vision. And there are many, many modifications which keep coming on how to choose the rings, how their size, their width, so that, the problems of light utilization, the problem of contrast, glare hairs becomes less and less. So I won't go into the real optics of it because I want you to get an overview on how to, incorporate more and more presbyopic lenses in your practice. Optics we can discuss later, but on a comparative basis, like if you look at various lenses, you will know that which lens is offering you what kind of correction. For example, one company will say that, okay, I'm smoothing out my steps so that there is no glare and halogens from the edge. So if the person is night driving, I would probably choose this lens which is offering me less night and glare. Now, when you're operating, no major fancy changes in your phaco surgery. I'm sure you're a temporal surgeon by now because that's astigmatic neutral. Make sure that your CC is good because we want an overlapping coverage on your IOL so that it's centered properly. Make sure that you aspirate your visco from behind the lens so that there is no decentration once you're out. Similar reason, proper wound hydration. And on how to check the centration of your lens. Normally what I do is at the end of the surgery, I ask the patient to look directly into the microscope light, and I try to get the Purkinje's image into the center of the optic, though ultimately it doesn't matter. It takes up the size of the capsule only, but still it gives you a good feeling if you've centered your lens well. So out of the big bracket of trifocal versus EDOF, I would say that, for me, I feel trifocals give you a very good range because EDF, all said and done, the near vision, like if your patient is a close reader, does get a bit compromised, and you have to do these tweaks of one eye dominant distance, and then the other eye you keep a little myopic kind of a micro monovision, which trifocals you don't have to bother about. And once you've mastered your presbyopia, then you incorporate your astigmatism into correcting presbyopia. So you can start picking up patients with astigmatism. If it is less than 0.75, you can do an LRI, or you can place your incision on the steep axis. If it's higher than that, then you have the option of, things like trifocal and EDO, the plate haptics, toric to begin with that. And as I said, use multiple instruments to get your power and axis correct. So you have enough to pick and choose from, but let's not forget, there may be a situation where your patient is not paying in the paying capacity. You don't want to take a chance, but you still want to give him a decent range. The good old monovision is good, where you keep, you should know how to know the dominant eye distance, and depending on his reading or intermediate need. One thing which everybody can adapt is the enhanced monofocal, because it gives you the distance and a bit of intermediate also. So apart from all the presbyopic, I just wanted to highlight these two lenses also, which are giving you more range than just correcting the distance ones. So major thing in your refractive practice is, do not say the word get rid of glasses. As long as you're saying that you decrease the spectacle dependence, you will be very good. And just starting good is a job well done. So thank you, and we can have a discussion after this.